we'll go to the next speaker. The next speaker is the youngest speaker of this session, Dr. Maskati. Thanks for, he's balancing the act in 2 halls, just finished the quiz in 1 hall, I guess. And he's going to speak on corneal patch graft.
Okay, so right away, thanks to Dr. Somashila and SSEI for help with some of the videos. As you can note from the message, all cases and videos seen in this presentation except on the title slide and perhaps the last slide are courtesy Dr. Somashila. So let's go on with the presentations. The first one is a case of pterygium excision followed by echo, followed by microbial keratitis fungal with perforation and end off, and the plan was a corneal scleral patch, and that was what exactly was done. So in a peripheral area, there are more than 1 ways to skin a cat. Dr. Kavita showed us elegantly the use of a tenon patch graft. You can also, if you have tissue available, use a cornea there. So important thing is to go beyond the edge, because the edge may be cheesy and difficult to suture. So go a little beyond, use a marking pen and go a little beyond. Then put your graft, the entire cornea there, then put it there so that you'll get an idea of how much you need and how much to cut. Err on the side of little larger, because you can always cut it, trim it after that. And sclera, cornea doesn't really matter. They're almost the same once you put it in that area. The idea is to try and save the eye. I don't like continuous sutures, so it's always interrupted in any therapeutic graft, whether it's a central graft or a graft like this, tectonic. Use interrupted sutures. You can open the conjunctiva and go underneath as well, so that you get the full extent. So this was the second case of blunt trauma with a patient who was pre-existing pellucid marginal degeneration with a perforation inferiorly. Patient had already had a tenon patch graft, so then there was nothing else to do except a corneal graft. So again, a whole cornea is being put there so that you can choose the size. Use an old marking pen so that you get nice big marks which will not erase. See that you don't chop off iris at the same time. This is a disposable trifine. You can make 2 cuts, 2 different concentric cuts if you like, or you can do freehand. The second cut can be freehand. So I put it on the cornea, then mark it out accordingly, and then put this. You can always trim it afterwards, take a little larger piece. This is Dr. Somashila's video. Evidently, she's in love with that marking pen.
It's from my colleague.
And then the rest is tailoring. Post-op, this patient actually had 20 by 60. So it's possible to get fairly useful vision if it's in the periphery. This is a patient with Terrien's marginal degeneration, differs from Murren's because it is not painful, but a slight trauma can cause a perforation. This is what happened with an inferior corneal perforation with iris prolapse. So corneal patch graft was planned again. So first you reform the chamber. What do we do with that iris? We can tuck it in because evidently there's no infection. It's not a road traffic accident. If that was so, you would not tuck in an iris, but you can try and tuck it in. You do a small iridectomy there and try and preserve as much of the iris as you can. Again, the same principle. Here you're making the use of remnants of a PK which has been used, so the remaining part of the cornea can be used. So if you are in a high volume center where you have such things, you don't have to sacrifice normal cornea. You can take the remnants from a PK patient. And as I said, if sclera comes along with it, it doesn't really matter. And suture it, open the conjunctiva a little, do a peritomy so that you can suture edges nicely, and you can always trim as required. So this is post-op 18 months with a small cylinder, is doing reasonably well with 618 vision. And this is a one-eyed patient, graft versus host disease following bone marrow transplant for sickle cell anemia. To complicate things, because of graft versus host, severe dry eye, and a one-eyed patient. So this is how it was tackled. So again, some things which I keep repeating: open the conjunctiva well beyond the margins of the perforated area. Then you can use a trephine with a marker to mark, or you can use the pen. And Dr. Somashila uses variety of instruments, including iris depositors, to mark. Take care to preserve as much iris as you can. Not all of us are adept at iris suturing in the second stage with self-created iridodialysis, so avoid that. She is very careful to preserve as much iris as she can. So what suture do you use? 10-0 nylon, 9-0 nylon is what you would prefer. I don't like vicryl sutures as far as this is concerned, and the rest is similar to what I mentioned. Form the chamber afterwards with air so that you know you've got everything, that there are no synechiae there. Push in visco first, wash it out, and then at the end you can put in air. So you're making sure that the chamber is formed in the area where you put the patch graft, that there are no synechiae there. And then air will ensure that that remains a good chamber for at least a couple of days before the aqueous takes over. So post-op again, this patient did reasonably well. You could salvage this eye, and the immunosuppression could actually be stopped after a year. And this patient then developed a cataract, which was then operated. And the patient did see well. I have no patients in whom patients saw that well, so I borrowed all the surgical videos from Dr. Somashila. Thank you so much for your attention. Thank you.